So we shall go on to our next set of debates, which is going to be led by Dr. Nikhil Gokhale, a leading cornea surgeon with more than 20 years of eminence from Gokhale Eye Foundation, Mumbai. And he's going to debate on primary management of persistent epithelial defect with AMG. And he's going to be countered by Dr. Vikas Mittal, who is from LGI Institute, Ambala, with prolific skills in corneal surgeries and laser vision correction. And he is going to talk about being conservative with persistent epithelial defect. So let's hear from you, Dr. Nikhil.
You can see my slides?
Yeah. Yes, yes.
So basically, when we talk of a persistent epithelial defect, we see a heaped up margin, and basically there is some amount of inflammation which is going on there, activation of myofibroblasts, collagenases which are causing stromal necrosis, and there is some scar formation tissue in most of these patients. When you look at the key mechanisms, you have mechanical trauma, inflammation, limbal deficiency, neurotrophic factors, basement membrane injury, ear film problems, and sometimes medication toxicity, which basically lead to a PED. We have the standard treatment regimens, which basically where you need to treat the underlying conditions, stop the toxic drops, use plenty of lubricants, bandage lanes, debridement, tarsorrhaphy, and doxycycline. And then when you have more refractory cases, one would use autologous serum, one would use contact lenses and AMGs. And then you have certain growth factors and nerve growth factors more recently, which is used in some of the cases could be used sort of thing. Now, if you try to sit on a PED, we know it leads to ulceration, melting, perforation, scarring, visual loss. You can get secondary infection. These eyes get vascularized. And very often you might end up doing a cyanoacrylate glue or a therapeutic keratoplasty. So when you look at amniotic membrane grafting, I would mention that using an AMG and combining it with a tarsorrhaphy and BCL, the way I would prefer to do it, it will target most of the mechanisms that are responsible for a PED. So it will reduce the mechanical injury onto the ocular surface. We know it is anti-inflammatory. It promotes epithelialization, reduces apoptosis, has several growth factors, can increase the nerve growth factor signaling by itself. It provides a healthy basement membrane for cells to grow and rapidly epithelialize. And therefore, and even if you see some of the complications that you get with conventional treatment, for example, if you have corneal tissue loss or a melting of the cornea, you can put multiple layers of AMG which can restore the corneal thickness. We know the AMG has anti-scarring effect, so there will be the vision would be much better in these patients because the corneal structure is somewhat restored. The AMG also gives you the advantage of reducing the risk of infection by covering the bare surface area and has some antimicrobial effects. We know it's anti-angiogenic, so the vascularization in these eyes is much less. So if you need a subsequent procedure, they are a much better chance of success as compared to maybe a cyanoacrylate glue. And using it early can help you prevent doing unnecessary therapeutic keratoplasties, which often fail and make subsequent interventions more risky and difficult to survive. Just remember that whenever you talk of an AMG, it should be a cryopreserved AMG and not really a dry amniotic membrane or gamma radiated membrane, which is just sort of a tectonic and does not have much of biological properties. You could put the AMG in several ways. It could be an inlay graft, which provides a new basement membrane on which epithelium can grow. It could be just an overlay patch, which allows the epithelium to grow under it. And when you have significant stromal loss, it will be multiplied with the AMG growing in between the topmost layer and the patches of layers below. So, of course, it's not a panacea for anything like that. You can have problems which are not sort of taken care by the AMG. For example, factors such as ischemia, persistent exposure, severe neurotrophic states of the cornea, infection if it develops, severe tear film disorders, patients with large perforations or extreme thinning may not be manageable. And then if you have relentless inflammation, the treatment itself can therefore fail. Just to show you 2 or 3 quick cases, this was a patient with a Pseudomonas corneal ulcer. Treated the infection sterilized, but he had an extremely large PED with a very thin cornea, and I knew that treating him with any other way would lead to only perforation and a therapeutic graft. So I did a double layer AMG with oral doxycycline, and this is his picture. What you can see is that he's a good candidate now for a DALC or a PKP, and there is scarring but minimal vascularization, so it's not a high risk graft, which would otherwise result if I had done any glue procedure, or I would have sort of done a therapeutic graft had he perforated. And this is a HIV positive patient with post-HZO necrotizing inflammation, neurotrophic ulcer. Again, I did a AMG with BCL with tarsorrhaphy, and he has about 636 vision subsequently with a stable surface. At least we could get him out of the trouble fairly reliably. As I mentioned, it's not a panacea. So in this chemical burns, ischemia cannot be treated by just an AMG, and therefore you need to do a tenonplasty. But with AMG and tenonplasty for these non-healing defects, otherwise you can get a good outcome. So I think most patients, by the time they get diagnosed as a PED, have already encountered lubricants, patching, bandage lenses, trying to modulate their medications, and have had anti-inflammatory therapy. And in these, the options that we have are maybe an amniotic membrane, a tarsorrhaphy alone, maybe use of scleral lenses and autologous serum. And given the cost factors and the various patients that come to our clinics, I think, and the risk of infection, I think the AMG and probably with a tarsorrhaphy or without a tarsorrhaphy is the gold standard for me in most of my patients. And when you put an AMG, remember which way to put it, up or down, and that a Wexel sponge is just more than enough to help you identify the layer. Thank you.
Thank you very much, Dr. Nikhil. That was wonderful.